yes, nice to meet everyone. I'm Shallin. So this is my presentation. It's not a huge or elaborate presentation, and I'm very happy for anyone to interrupt and ask questions and to treat it relatively informally. So this is looking at the emergency department management forearm fractures, which is what we're all here to discuss today. Now, it's difficult to do this without talking about BOA standards and sort of the BOST guidelines, and without giving you a very large bit of text. I mean, the salient point of this slide is to draw your attention to the fact that we need a suitable location to do this, where we can have appropriate monitoring and where we can provide casts. Now, for most things, that is indeed the emergency department, and it should be performed by a competent orthopaedic practitioner, which would be ourselves or the registrars or appropriately trained SHOs. Now, both of those are things that are available in hospitals 24 hours a day, 7 days a week. So that shouldn't be a stumbling point. And this is our guidelines nationally from the BOA and as per BISCOS as well, and from the Royal College of Emergency Medicine. So the first slide then is the BOA guidelines, and it's quite a long sort of bit of text, but the area in red is the bit that we probably should focus on, which is that what I said earlier, that we have a safe environment. That is the emergency department, where we have monitoring, we have the appropriate setting to provide safe, I would say, anesthesia or analgesia, and we do have the expertise because there is a 24/7 orthopedic on call. So, right, so what are our other guidelines? Obviously, everyone's aware of GIRFT, getting it right first time. Now, that did start off with PROPREX as being largely an orthopedic directive. However, obviously, it's found its way into most other specialties. So the idea is that, well, as the name suggests, the aim is to get things right the first time and to reduce variations both locally and nationally. So what are the other reasons? Purely from a pragmatic point of view, there are patient factors and patient reasons for doing it, but there's also fiscal reasons and efficiency reasons. So the area that I've sort of highlighted here in the text is that through doing this in ED, we are actually saving about 250 weeks of operating time a year. And this is what has been previously or historically dedicated to reducing these fractures in theatre. So obviously that does bring theatre efficiency down a lot, and also from a fiscal point of view is quite expensive. So how are we doing as a region compared to in terms of our reduction of forearm fractures versus a national average? So not badly. If you look at the median average, we are ahead. Now this makes some inferences. Now this makes the inference that for every fracture that doesn't go to theatre, that has been manipulated in ED. That's sort of the inference we're making. Now, if you look at that as an inverse relationship, we're not doing terribly, but obviously there is room for improvement. And looking at our trust, Ashford St Peters, we just seem to be doing quite well. And as a provider collaborative, I mean, I think in general, the South Thames Paediatric Network is doing well in terms of getting our forearm fractures reduced. But there is still a variation, and that variation exists both through hospitals, but also more locally within trusts itself, and depending on who's on call, whether it be registrar consultant wise or whoever's in ED. So our aim is actually to try and reduce that down so that there is a framework that is universally accepted and reduces these variations. And that's kind of what this is sort of centering on as well. So the key questions here are, is there some way we can support our colleagues in ED, both in ED and orthopedics, to try and get these reduced in the emergency department? And why are we doing this? So obviously we've talked about theatre efficiency, but actually it's a smoother experience for the child and the family as well. Now, I have a son called Alex. Now, if I brought Alex into the hospital and I was taken through, in layman's terms, told that he needed to have surgery, that has a lot of psychological burden on both myself and my child. Obviously, there are the risks of anaesthetic, and they're not just the risk of airway problems with anaesthetic. There's also plenty of data out there which suggests that having a general anaesthetic does have deleterious effects on a child's IQ and particularly in the pre-adolescent brain. So I think children and their families are a lot more accepting of it than would be historically presumed. Now, what are the barriers? The next question is, what are the barriers to changing practice and how can these be overcome? And I think a lot of this is education, both for ourselves as clinical practitioners, but also for, for families and the rest of the wider staff. Now, I'm not going to go on about this at length. Now, this is the girth forearm fracture pathway. Just to look at it very briefly, and from the point of view of the people who are here, when your patient or your child presents to ED, you have to find out whether they have a fracture. Now, is the next question, which is the crux, is this a fracture that can be appropriately reduced in the emergency department, or is it likely to need surgical intervention anyway, i.e. is it going to need flexible wiring, plating, etc., or some sort of associated procedure? Now, if the answer is yes, that answer needs to be coming probably from the orthopaedic team. So as soon as you've made the decision about whether a fracture needs reducing, the how, where, and when should be the onus you should be putting on orthopedics to come down and make that assessment about whether it is something that can be reduced by themselves in the emergency department, or whether that will need reduction in ED, often because it's a high energy injury. Sometimes they're open and sometimes they need adjunctive procedures. Now, how do we go about doing that? So looking at Nottingham's case study, results, they found their results were just as good in the emergency department as those achieved under an anaesthetic in theatre. And that is saying quite a lot, because actually in theatre you've got a fully asleep patient and you've got X-ray at your behest. So to have the same results, that's just a testament to how well this can be done. Now I think, and I don't think this is a problem here, I think that's why results are quite good. There can be some resistance from ED staff, and quite rightly so, because everyone is looking out for the patient, and sometimes it can seem barbaric doing these things in the emergency department. But I think a lot of it has to be looked at as a benefit-risk ratio. Now, the risks or the negative points of having your fracture reduced or a child's fracture reduced in the emergency department is, it is painful. Even despite adequate analgesia, it is going to be quite sore. But just because we're not seeing the after effects outside of ED doesn't mean that there is a, that they go onto a ward, have the manipulation done the next day by ourselves in theatre. That is not without risk and without pain itself. The child has to come in, be taken out of their natural environment, because often this will be done the next day on the list. They have to be starved. They then have to have a cannula, and most children are pretty needle phobic, and they don't like the idea of having the cannula inserted. And then obviously there's the risks of anaesthetic. Now, I was here when I was doing my fellowship there actually in Hands when this was done, this sort of directive at Royal Berkshire. And it finds similar things, that it needs to be a collaborative effort between the emergency department and orthopaedics, with early escalation of fracture need reduction to the orthopaedic on-call team. They would then be responsible for appropriate reduction, with the onus for sedation falling on ED. And I think that is also an area which has been a stumbling block, because when you've got a very busy ED, which is the case most of the time now, it is difficult to find someone who will be available to sedate at short notice. And this can be a stumbling block. Now, again, this is looking at historical data, and there has been a bit of a block when looking at ketamine and propofol and conscious sedation, because you do need ED available, and you need someone who's relatively airway trained just in case this goes wrong, because these are drugs that are given as general anaesthetic. And this makes it a problem, because not everyone is airway trained downstairs in ED. It relies on a consultant, and not all of the consultants are airway trained either. Now, this brings us on to the next thing, and this is just a ketamine, and it's quite an involved, if you read this, it's quite an involved protocol using ketamine. So is this appropriate? Well, not always. And what we've been doing here is using, as per the Royal Berkshire experience, using intranasal opiates with Entonox. Now, these are sufficiently analgesic that it takes away a lot of the pain, which is usually momentary, because you usually do it at the same time you're putting your cast on. Now, they offer similar pain relief. Where there is a bit of a problem is you don't have the amnesic effects of the anaesthetic. So whilst the child is probably still experiencing a reasonable amount of pain with sedation with propofol and ketamine, there is amnesia, and therefore their recollection of that pain is not the same. And I think this is probably the way things need to be going, because this is a lot more likely to be successfully implemented and used in various trusts, because these are two things that are widely available. They can be prescribed by the on-call team. They don't need formal airway training or airway protection, and they don't need the very busy ED consultant or ED registrar to be pulled away from the patient in resus who needs their care and attention. And this, to be honest with you, can be administered by the orthopaedic on-call team when they come down to manipulate the fracture. So I think this is probably the way things are going. This is just a list of resources that are quite useful when looking at manipulating fractures in the emergency department. That is me done.